A very good afternoon, all. I am Dr. Shenila Memon, Senior Registrar of the Pediatric Medicine Department of the Indus Hospital. Thank you for joining us for the Pediatric Medicine session of the ICON 2022 conference. We are delighted to have our international speakers and the audience given the virtual nature of the conference in this challenging time. The theme of the conference, Beyond the Call of the Duty, reflects the courage and the hard work of the frontline health worker, including the caring of the children's. Children have borne the brunt of the multiple COVID 19 waves with loss of parents, family incomes, education, facilities, and lack of immunization. Our session today is the combination of the talk by the expert that focus on the problems that ranges from the newborn survival, acute kidney injuries in the sick child, and the chronic condition like cystic fibrosis, to measures to improve the care of children across the Pakistan to enhance the teaching circular. I will introduce each speaker before the talk, play their talk, and then at the end of the session, we have a panel discussion with the speakers and the experts. And we encourage you to post your questions in the chat, preferably with the name of the speakers to whom the question has been addressed. I also request you all to fill the feedback form at the end of the session for your e-certifications. Moving forward to our session. Our first topic for discussion is management of the cystic fibrosis by Dr. Ali Akbar. Dr. Ali Akbar specialized in the pediatric respiratory medicines and the cystic fibrosis from the UK. He has been working in the field for nearly 25 years with the research on DNAs in the mild lung disease and anti-pseudomonal salivary antibodies response in children with this cystic fibrosis. He holds an FRCP-CH and FRCP London and is an honorary visiting professor of the pediatric at the ICH Lahore. And he is also a senior examiner for MRCP-CH and DCH exams. He has spoken at many international conferences. His goal is to raise awareness of the cystic fibrosis, improves the standard of the care and facility of the establishment of the cystic fibrosis in the cystic fibrosis centers in Pakistan. Dr. Ali Akbar, management of the cystic fibrosis.
Assalamu alaikum wa rahmatullahi wa barakatuhu. I'm Dr. Ali Akbar. I'm a consultant respiratory pediatrician based in Birmingham, UK. I would like to thank the organizing committee and in particular the pediatric department at the Indus Hospital to invite me for this prestigious conference with the theme Beyond the Call of Duty. I congratulate the Indus Hospital for all its tremendous efforts and services to the community, enabling the financially less well-off families to access their services. I have previously been to Indus Hospital, and this is 3 years ago when Dr. Fayyaz, who is shown in the picture, invited me to come over and to do 2 days of cystic fibrosis workshops at the Indus Hospital. Before I start the presentation, I would like to say that I have no conflicts of interest at all, and there are no sponsorships for this talk. I would like to introduce the topic to you as cystic fibrosis, not commonly known in Pakistan. CF is an autosomal recessive condition. It was first described in 1938, but the genetics were only worked out in the 80s. In 1985, it was found that the gene for the cystic fibrosis disease is located on chromosome 7 on the long arm, and in 1989, the CFTR gene itself was identified. The CF itself is a multi-organ disease, but mainly affects the lungs and the gut. In the West, over the last 80 years or so, the survival has tremendously increased from where children used to die before the school age, now surviving to the middle age. And this is before these mutation-specific medicines have become available over the last decade. The main causes of death in cystic fibrosis are listed on this slide. And as you can see, in about 80% of the cases, these are related to the respiratory infections. To do the management of cystic fibrosis in such a short time is not possible. I have therefore concentrated on the treatment of the respiratory diseases, and in particular, the main organism that causes the chest infections. Respiratory infections in cystic fibrosis are caused by various organisms. In the early young childhood life, it is usually Staph aureus, Haemophilus influenza, and over the time, Pseudomonas aeruginosa takes over. These cause recurrent chest infections leading to bronchiectasis and chronic respiratory failure, which is the main cause of death in children with cystic fibrosis. The management of this condition, of these infections, requires the understanding of the underlying pathophysiology. And if we go back to the CFTR gene, which was discovered in 1989, the CFTR gene is defective. There are over 2,100 different mutations causing the disease. In Pakistan, Delta F508 is only found in 1/3 of the patients. The other two-thirds of the patients find other diseases, other mutations. The CFTR gene causes a defective protein within the cell, which is unable to get to the epithelial surface, where it tends to control the chloride channel. With the absence of active chloride channel, the layer on the top of the epithelium becomes dehydrated and causes thickness of the mucus, which then becomes infected and causes the chest infections. This infection causes inflammation, which further increases the mucus production, and this vicious cycle tends to generate further infection within the lung, causing bronchiectasis in the longer term. Now, to understand pathophysiology a little bit better, this is not the only cause, because CF mutations, as I said, do cause the impaired clearance, mucociliary clearance through thick mucus and chest infections, but there are gene modifiers around there. Now, you could imagine these gene modifiers as the microenvironment of the CFTR gene. Now, these are just like in the community, when somebody's doing a bad job, other people come along and say, behave yourself, do something better. Or alternatively, if you've got a bad company, then they may make you do the wrong things as well. So these gene mutations or gene modifiers also affect how the CF mutations work. In addition, there is the macroenvironment, and we will discuss this in the presentation later on, which then cause further impaired clearance of the mucus and introduction to the bugs which cause the chest infection. So the management of respiratory infection cystic fibrosis is based on 4 principles of prevention, detection, eradication, and suppression of the infection. So if we consider in the first instance this diagram again, the gene modifiers, unfortunately, we have not been able to identify anything that can prevent those. We are born with those and we can't change this. And over the length of this process, the prevention is very, very important factor, because if we can prevent these, then the detection, eradication, and suppression can be managed and will be less troublesome. And prevention is always better than the cure. So looking at how we can prevent these things, if we look at the gene modifiers, I said we are unable to modify those, so that is out of the question. Now we can concentrate on the CF mutations on the left side of this slide. Now, if we look at the CF mutations, there are different groups of CF mutations causing different degree of problems in the cystic fibrosis patients. And in particular, what is currently happening is the mutations in the group 2, 3, and 4 can be managed. So there is the transport of protein from the nucleus to the epithelial surface can be improved, and its function at the epithelial level can also be improved. And there are now at least 4 different medications that are available to do so. The first one became available in 2012, and the latest was in 2019, Kaftrio or Trikafta, as it is known in the United States. Now, these are all dependent on what sort of mutation one carries, because if obviously children are carrying different mutations that are not going to respond to these medications, then it is no point having the medications. Also, these medications are extremely expensive. They cost around about 3 crore rupees in Pakistani money a year, and this is for life. This is not just for 1 month treatment or 2 months, but this is for life. And these medications are so expensive that even the governments in the West cannot afford. And we are currently awaiting for this Kaftrio or Trikafta to be licensed for children from 6 years upwards. Currently, it is licensed for 12 years upwards, and it has to have 1 copy of Delta 508 along with one of the other mutations. And as I said, there are at least 2,100 different mutations causing cystic fibrosis. So these have revolutionized the treatment of cystic fibrosis, but this is currently very expensive. Unfortunately, these medications are not yet available in Pakistan, and we have inquired about its availability being made in Pakistan, but unfortunately, this is not the case at present. There are other countries starting manufacturing these medicines, which may be cheaper than the price in the West. Now, looking at the other ways of preventing, this thick mucus causing impaired mucociliary clearance can be affected by other factors. And if we look at this vicious cycle, there is the hydration. So if child is hydrated, the mucus is going to become more thick and cause the airway obstruction. So one should avoid all cases where hydration is a risk. So in summer, when children are sweating a lot or when they got gastroenteritis, then people need to be given extra fluids. Also, with fluid loss, they lose quite a lot of salt, and therefore salt replacement in hot weather is also important. In addition to keeping children hydrated, there are other ways of making the mucus thin and more expectorable. These are hypertonic salines of varying degrees. Not everybody needs all these medications. These medications are very personalized, and every individual child had to be assessed at their own abilities and their needs before these are given to them. So hypertonic saline, the 7% nebulized hypertonic saline twice a day tend to work the best, and it can be given in the younger age group as well. There are obviously other circumstances, like in bronchiolitis, where 3% saline has been used, and it can also be used as well as normal saline to thin the secretions. But when the secretions are quite thick and persistent and causing recurrent chest infection, 7% is the best in the market at present. The other availabilities are polymyxin, which is DNase, which is given once a day. This is quite a lot expensive as well, in addition to other medications that may or may not be available in Pakistan at present. But these are the options available to clear the mucus from the lungs. The other ways to clear the airways are by increasing child physical activity, where they are jumping up and down and mobilizing the secretions within the airways and then coughing them out. In addition to display, which is very important in children, not only for chest clearance, but also for musculoskeletal system, they can have other devices to help them along with the chest physio and chest clearance. These devices, again, may or may not be available or can be modified to the need in Pakistan. For example, I've shown you this bottle with a straw with water in it. This can be what we call the PEP, positive end expiratory pressure, that expands the airways and mobilizes the secretions in the airways. So these are different techniques that can be employed in the children with cystic fibrosis to clear their chest, and physiotherapists can advise the families accordingly. Now, coming on to the macroenvironment factors that can control the infection. Now, if we look at the early childhood, the nutritional status is extremely important in all the children. And as I said, gastro-respiratory problems are the main symptoms in children with cystic fibrosis. Their nutrition is very poor, and therefore the immunity is lowered as well. So it is very, very important to make sure that they gain weight satisfactorily through the ages and through their time. In addition to that, all the immunizations should be taken at time, and these includes various immunizations as I listed in the slide, which include TB and hip and measles, and currently the COVID infection as well. Also, exposure is important, and I think this is just like the COVID at the moment. Some people believe that COVID doesn't even exist, and the marriages are going on, gatherings are going on, people are intermingling, and there is no care at all. This is very important in cystic fibrosis, that we reduce their exposure. So if somebody does have any respiratory symptoms, we should make an effort to stop children mixing with those, in particular with other children with cystic fibrosis. Prophylactic antibiotics is the other way of preventing the infections, but there is some concern whether prophylactic antibiotics may predispose children to acquire Pseudomonas at an early stage. There are currently some studies going in UK, and I will mention that later on in the slide. And there have previously been work in the United States where cefalexin used to be used as a prophylaxis, and those children who received cefalexin were getting higher incidence of Pseudomonas aeruginosa infection, and therefore they stopped. So we will mention that, and these need to be monitored quite clearly. The other ways of keeping chest clear is making sure, like I said, with the prophylactic antibiotics, currently in early childhood, as we know, Staph aureus, Haemophilus, and Streptococcus pneumonia are the commonest organisms causing it. So fluproxycin, Coamexiclav are the commonest to use prophylactic in the UK. In older children, cotrimoxazole, which is Septron in Pakistan and Septrin in the UK, or doxycycline can be used for children over 12 years of age. Azithromycin has been used in all ages, and it has many functions. In addition to the antibacterial function, it is anti-inflammatory and also may have immune modulating factors as well. So these are the different antibiotics that have been used in different ages in cystic fibrosis to prevent the onset of infections. Regarding the fluproxycin, currently there is a START trial going on in the UK to look at the use of fluproxycin in children with cystic fibrosis, and it has got two arms: one who receive the fluproxycin all the time, and the others who don't, but only get treated if there is a positive culture. Now, this is to look at if these children will go on to acquire Pseudomonas aeruginosa at an early stage or not. The result will take some time to come out, but this trial is currently undergoing. Azithromycin has also been used extensively throughout the world. It basically goes back to days of chronic bronchiolitis or bronchiolitis obliterans in Japan, where they used azithromycin for a better effect. So as I said, it has multiple properties and it has been used in cystic fibrosis. There are studies supporting that it does not predispose to drug resistance, but it is important that these bugs and cultures are followed through. The other mechanisms, how we can treat respiratory infections in addition to prevention, as I mentioned above, are detection, eradication, and suppression. And these all require reliable and frequent airway sampling and microbiological cultures, which are currently, unfortunately, not done in Pakistan. The detection of infection, as I said, depends on the cultures, and cystic fibrosis children are prone to acquire infections from viruses, bacteria, atypical microorganisms, and fungi, like many other people. And these are the various cultures that we can send to detect these organisms. Unfortunately, at the present time, throat swab and tracheal excretion is the possibility, or the only possibility, that is carried on in Pakistan, unless somebody is intubated, in which case bronchoalveolar lavage can be sent. So there are difficulties in sending samples to the laboratory. There are problems with processing, as laboratories are not working together and they do not know if the sample may or may not have come from a CF patient and which particular culture to set up. So it is very, very important that laboratories talk between themselves, and there is a local lead and center that can inform the laboratories what cultures to set up. Now, with regard to the eradication, one obviously needs to know what organisms we are dealing with. And this slide, as I've shown you before, which is from the CF Trust in UK and CF Foundation from the United States, they all have the similar pattern. In the early stages, we tend to have Staph aureus, which with time declines, but still 25% of the patients carry on to have culture in the chronic state. Haemophilus influenza, which is shown in blue, tends to be more in the younger preschool age and then tends to decline with time. But over time, this red line, which is Pseudomonas aeruginosa, that predominates, and majority of patients with cystic fibrosis acquire this with time. And unfortunately, this does become quite virulent and resistant to the antibiotics over the time. And it is very important that we do these regular culture on these patients to make sure that we can optimize the treatment. However, the treatment in the CF countries and CF centers is not yet all unified, and there are differences in every center's approach. However, optimal treatment does require the cultures, and whenever we are given intravenous antibiotics, we need to make sure that we actually treat them with 2 antibiotics to stop any resistance developing. Now, chronic Pseudomonas infection is the worst consequences of these infections, causing chronic lung inflammation, deterioration in lung function, and overall poor prognosis. The availability of what we can do at the present time, there are at least 3 different options which I'm going to mention. This is option 1. In those children who acquire Pseudomonas aeruginosa for the first time, if they are well, they can be managed with oral ciprofloxacin for 3 weeks, in addition to nebulized colomycin, which again is not freely available in Pakistan. We normally tend to give it for at least 4 months and culture every month to see whether it has disappeared or not. If the child is unwell, then we give them IV antibiotics, and we give 2 usually ceftazidime and tobramycin, our choice in the first instance, followed by nebulized colomycin, again for at least 4 months, and cultures done every month. If the culture on monthly intervals, 3 consecutive cultures come back as negative, we take that this patient has been eradicated from their organisms, and we can therefore stop their nebulized treatment. However, if the 3 cultures are not positive and they regrow Pseudomonas, we can reattempt at eradication, but then they tend to carry on heminebulized treatment. Option 2, again, it depends whether the child is clinically well or not. If child is well, then they can have oral ciprofloxacin for 3 weeks, followed by nebulized tobramycin for at least 1 month, and then see if these children clear their organism or not. If they're unwell, again, they have 2 intravenous antibiotics in addition to nebulized tobramycin, at least for 1 month. And then I'll show you the next slide, where it actually shows what we do with them. So if, for example, they have spontaneous or induced sputum at the end of 1 month of nebulized tobramycin, if the culture is negative, then they have bronchoalveolar lavage undertaken. And this is because a negative culture doesn't necessarily mean they don't have the organism, because it could be just the culture dependent or false negative. If BAR becomes negative, then you can assume that the organism has been eradicated and subsequent nebulized treatment can be stopped. However, if BAR is positive, that means there's a failed eradication. Similarly, if the spontaneous or induced sputum in the first instance becomes positive again, then that means that the bug has not been eradicated. And in that particular case, we need to make sure that we carry on with the either re-eradication with oral ciprofloxacin, or give them further IV antibiotics and carry on with nebulized colomycin, nebulized tobramycin, or clistin, whichever is available and whatever combination a particular center is undertaking at that time. Option 3 is in those children who are actually well, but not able to tolerate oral ciprofloxacin. In that case, nebulized tobramycin for a variable period, but usually for 56 days, 8 weeks is sufficient in those patients, and that may eradicate the organism. However, cultures need to be done quite regularly, usually every month, to make sure subsequent cultures have become negative. Now, choice of antibiotics, if this is for intravenous antibiotics, can be variable between centers, but most commonly as a first line, ceftazidime and tobramycin is the first line choice. In the second line treatment, meropenem and tobramycin can be given. And in addition, if there is Staph aureus, then that is quite important to include meropenem. Subsequent choices can be culture dependent, and these will include amikacin, IV colistin, or aztreonam. The tazocin, which is also commonly used in Pakistan, is available, but it may be carrying a higher incidence of allergy in some of these patients. So one has to carefully look at the culture reports and also follow the patient needs and make sure that they're not reacting to any of these antibiotics. The long-term nebulized antibiotics in the UK, and for some time until more recently, colistin or IV or nebulized colomycin was commonly used. Then tobramycin and combination with the colistin has been used, and then the third generation aztreonam Caistin in the form of nebulized treatment has become available. So these are all very much dependent on the culture positive and culture bug sensitivities to the organisms, and therefore one needs to make sure that cultures are regularly done with these patients. Now, Pseudomonas aeruginosa, as I say, if one does not grow for 1 year, then one can assume that they have cleared that and it has been eradicated, and these long-term nebulized antibiotics can be stopped. If they continue to grow the Pseudomonas aeruginosa, then the nebulized antibiotics are continued. As there are different nebulizers used in cystic fibrosis, I thought it would be very important to tell what order they should be given in the CF patients, as the wrong order means that they could be ineffective. Usually bronchodilators in the form of salbutamol inhaler is given right at the beginning to open up the airways or to take care of any side effects with the medication which can cause bronchospasm. After the bronchodilator, one tends to give mucolytic agents such as hypertonic saline or pulmazine, and after which we tend to do the physiotherapy. Obviously, if somebody's taking pulmazine, then pulmazine needs usually 1 to 1.5 hours to be left in the chest before any physiotherapy is done. After physiotherapy, inhaled steroids, if somebody is taking them, and in Pakistan, Clenil tends to be used more frequently, and that should be given after the physiotherapy. And any nebulized antibiotics should also be given after the physiotherapy. In summary, therefore, pulmonary causes account for 80% of the deaths in cystic fibrosis, and prevention is very essential and of paramount importance. Drugs are available to eradicate these organisms, but these will be dependent on the culture sensitivity. Nebulized antibiotics in the long term should be considered according to the cultures and the clinical status of the patient. And these patients need regular review by the dietitian, physiotherapist, and clinicians, and have a coordinated care. Now, just because this conference has been given theme beyond the call of duty, I think the challenge to the Pakistani medical community is to actually set up the CF services with multiple disciplinary teams and do regular cultures and clinics on a regular basis to make sure that we optimize the availability and the treatment of these infections, as well as other support, which could be financial and medical. And I must say that we have been working with the Pakistani CF patients, and we have a WhatsApp group of these patients. We also have a YouTube channel entitled Pakistan Cystic Fibrosis Support Network, which people can see, and there are at least about 50 videos uploaded in Urdu about information about cystic fibrosis, which people will find useful. I like to thank everybody for listening to me, and if there were any questions, I'll take those at the end. Thank you.
Thank you so much, Dr. Akbar. This is very informative talk. Now the next talk lined up is Approach to Acute Kidney Injury in Children by Dr. Farhana Amanullah. Dr. Farhana Amanullah is board certified pediatrician and pediatric nephrologist with over 20 years of clinical and research experiences. She established pediatric nephrology services and developed integrated nephrourology and nephro-oncology services at the Indus Hospital and its networks. She is the current General Secretary of the Nephrology Group of Pakistan Pediatric Association. Dr. Farhan.
I want to start by thanking the ICON 2022 organizers for inviting me to speak on this really important topic for children, that is pediatric acute kidney injury. And thank you for the introduction. The overview of my talk is that I'll quickly give you some background, the definitions of acute kidney injury in children, pathophysiology, a little bit about investigations, management, and then follow up. So what is acute kidney injury? Acute kidney injury is the reversible loss of normal kidney function. It is identified by a decrease in urine output and or an increase in serum creatinine, resulting in a reduction in the glomerular filtration rate. Acute kidney injury is going to affect the regulation of your fluid balance, acid-base balance, as well as your electrolyte balance. This is an important study that was published in the New England Journal of Medicine in 2017. That was the first meta-analysis of its kind in adults. The importance of this study is highlighted by the fact that acute kidney injuries standardized definitions were really not available up until I think I would say about a decade ago. The findings were that the AKI incidence is estimated to be 27 to 42% in large pediatric ICUs and at least 5% in the non-ICU admissions, indicating that as many as half the children admitted in the pediatric ICU can have some form of AKI. Another study from North America also looking at all the admissions, all the hospital admissions, also found that there is a significant incidence of AKI among all hospital admissions, particularly among children 15 to 18 years of age, who had a higher incidence, as well as the mortality associated with AKI was significant, which is 15% compared to 0.6% in regular admissions. Children are not may not be as accurately reflected. However, it is important to understand that things like shock, sepsis, underlying surgery can all overlie each other. So this is really it can be a multifactorial causation for acute kidney injury. Again, in certain setups, things like cancer would probably be a larger circle, and obstruction would also be a larger circle, and particularly in children. Again, looking at the underlying causes of acute kidney injury, sort of the pathophysiology or the sequence of events rather in acute kidney injury. If we look at the levels of markers along the y-axis and the duration of AKI along the x-axis, we find that the damage markers or the newer biomarkers actually start to go up much, much earlier than the functional biomarkers that we use to define AKI, that is the serum creatinine and urine output. This is the phase where the kidney insult has occurred, or the development phase, and this phase is now going into the injury phase, which is where our functional biomarkers really go up. And then if the duration of the injury is longer and it is not well controlled, then you enter into a phase where the recovery phase may be significantly delayed, and you may actually start to develop sequelae such as chronic kidney disease, depending upon the duration of your acute kidney injury insult. Again, looking at the pathophysiology, when you've had the primary insult, which is tubular damage, this leads to an adaptive fall in glomerular filtration rate due to vasoconstriction, leading to further damage to the epithelial cells, intraluminal tubular obstruction, and leakage of glomerular filtrate, leading to further neutrophil adherence to the ischemic endothelium and release of inflammatory mediators. What you see in the urine microscopy is these dead tubular epithelial cells in the form of the pigmented muddy brown granular casts that you would see in acute tubular necrosis. Looking at the various underlying causes in children, the functional acute kidney injury is primarily because of reduction in the kidney blood flow. And that can happen with severe hypovolemia, vasodilation in other parts of the body due to sepsis medications, reduced cardiac output, vascular occlusion, etc. And then intrinsic renal causes are to do with the glomerular nephritis, as well as tubular damage, and interstitial tubular interstitial nephritis. And post-renal causes are, of course, the outflow obstruction, such as posterior urethral valves, renal stones, tumors on neuropathic bladder. When taking a history of a child with acute kidney injury, you have to be really cognizant of what their fluid intake has been like, what their urine output is like, what is the frequency, what is the flow, what is the appearance of the urine if they have urine, have they had fever, have they had any recent GI losses like vomiting and diarrhea, with particular focus to bloody diarrhea, which could be associated with hemolytic uremic syndrome. Easy bruising or bleeding is another something that you would focus on as well. Underlying renal pathology, family history of renal pathologies, history of birth asphyxia, NICU admissions, nephrotoxic medication exposure such as ibuprofen, and systemic involvement, including rashes, joint pains, a recent throat or skin infection would, of course, be other things that you would focus on. Again, children who are at increased risk of AKI would be children with underlying nephrurologic disease, children who had undergone any cardiac procedure or have cardiac disease, liver disease, malignancy, and bone marrow transplant. Of course, in assessment, you would do your A, B, C, D, E. You would focus on their fluid hydration status and their hemodynamics, particularly the blood pressure, the urine output, and the urine output also in terms of response to any intervention that you might do in terms of providing them fluid, etc. You would want to catheterize them and also evaluate, measure their current weight and compare it to any recent weights that you might have. Response to fluid status is a very important step in managing AKI. When you have a child who is hypovolemic and you've given them a fluid bolus, you want to assess their urine output immediately after, soon after. And a child who is euvolemic, and you've given them a fluid challenge, again, the response to the fluid challenge in terms of the urine output is extremely important. A child who is hypervolemic, however, and you've given them Lasix, you want to again assess their response in terms of their urine output and plan early dialysis if there is none. AKI investigations, of course, are focused around what the underlying, what you think your clinical judgment is in terms of what the underlying cause may be. Of course, the urine dip, microscopy, culture, and protein creatinine ratio are something that we are obsessed about in nephrology, and they give you important clues as to their hydration status, their underlying infection, hematuria, proteinuria, again, in terms of glomerulonephritis and presence of casts is something we also obsess about if you have urine output and a urine microscopy. Urinary lights and urine osmolality are also important things, but only in as far as functional AKI is concerned, but not of much use if you've given them a diuretic or the child is obstructed. CBC, peripheral film, LDH, and platelet counts are, of course, important for children who may have hemolytic uremic syndrome, malignancy, and infections. Urea, creatinine, electrolytes, bone profile, PTH, if there is any underlying CKD, LFTs, glucose, etc., become important, obviously, as further investigations for AKI. Estimating your glomerular filtration rate by multiplying the height in centimeters with a K or constant, which is 0.413, divided by the serum creatinine would give you, would again help you quantify or classify the stage of acute kidney injury, and also to further follow the child up. Blood culture CRP in children with sepsis and inflammatory conditions, coagulation screen for sepsis, as well as when you're planning a renal biopsy, ABG lactate for metabolic acidosis assessment, tissue perfusion. Ultrasound becomes really important when you're assessing children who may have other structural issues with their kidneys. Doppler for, of course, renal vascular issues, and of course the overall ultrasound in terms of looking for obstruction and involving the urology teams earlier on. And then there are secondary, investigations and further investigations, including the autoimmune screen when you're assessing a child with acute GN, as well as planning for renal biopsy, looking at the echo when you're suspecting underlying cardiac conditions leading to acute kidney injury, etc. Then it's very important to remember that there are underlying drugs that can interfere with kidney perfusion, and you have to be careful with those drugs with children with AKI, and these include ACE inhibitors and angiotensin receptor blockers that can also cause hyperkalemia and reduce your renal perfusion. NSAIDs and diuretics would be the others that would impact renal perfusion. And then there are drugs that require dose reduction or dose adjustment or complete cessation when children with AKI. Close monitoring drugs or further drugs that need to be stopped in AKI would be calcineurin inhibitors, aminoglycosides, and antiepileptics that need to be adjusted. Now, a quick mention of AKI biomarkers, because it's something that you hear about whenever you talk about AKI advancements. However, despite significant research in this area, we still have not been able to get these biomarkers into clinical practice. There are some issues around the biomarkers, cystatin C and GAL, and the biggest one is that although they begin to rise very early on in acute kidney injury, they have not been really looked at in different situations of AKI in children. And also, another issue is that they're not terribly specific and can rise in other inflammatory conditions as well. So that limits their use. So what are the various strategies to minimize AKI progression? I think one would be to optimize kidney perfusion and to optimize kidney perfusion and to minimize iatrogenic insults, control your acid-base balance and electrolyte abnormalities, and optimize your urinary drainage. And there are various steps that you can take to do that are listed here. And the most important being your optimizing your fluid management. Of course, as you know, there is no drug that can fix acute kidney injury. You have your treatment really has to be around optimizing the child's clinical condition. And of course, minimizing the iatrogenic insults in terms of adjusting the drug dosages that I mentioned earlier, as well as controlling acid-base balance and electrolyte abnormalities, however, that initially through drugs and then later through dialysis. Urinary drainage optimization is extremely important for children who have an underlying urologic condition like congenital anomalies of kidneys and urinary tract, or are obstructed and may need urgent decompression. And then nephrology referrals are, of course, important in children who have underlying chronic kidney disease, in children whom you might suspect hemolytic uremic syndrome, in children not responding in terms of their hyperkalemia and metabolic acidosis to your medical management, in children who have symptomatic uremia and urea, in children who require toxin removal or have hyperammonemia. And the options that we bring in as nephrologists are peritoneal dialysis, intermittent hemodialysis, and continuous venovenous hemofiltration. CVVH is really the best way to manage acute kidney injury because it mimics your renal function. It is more gentle in its terms of its fluid removal and can be used in children with hemodynamic instability. Of course, this is something that requires more training and as well as capacity development, as well as significant resources, and is not readily available in parts of the developing world. And in terms of renal replacement therapy, peritoneal dialysis and intermittent hemodialysis is really really what is mostly used in our parts of the world. So in conclusion, for acute kidney injury in children, it is a common cause of morbidity and mortality worldwide, with the pediatric incidence being as high as 25% among all patients, and the mortality being as high as 30 to 50% for those needing a renal replacement therapy. And currently, continuous renal replacement therapy is the ideal treatment, but the cost and accessibility force several parts of the world to use adult equipment, peritoneal dialysis, and intermittent hemodialysis for critically ill patients who have acute kidney injury. Increased community awareness, of course, and training primary care providers to recognize and prevent acute kidney injury early on is really key, because the majority of the acute kidney injury really starts within the community. And of course, on a more global scale, there has to be stronger advocacy for the grassroots efforts to prevent acute kidney injury, and which is being done by the International Society of Nephrology. And this will be required if we want to fulfill the zero by 2025 mission, that is zero mortalities associated with the preventable acute kidney injury um, uh, as a cause of death among young children and adolescents. So thank you very much for this opportunity, and I would like to end here.
Thank you so much, Dr. Farhana. Our next topic is very interesting, which is about impact of the simulation-based curricula in improving pediatric care, obstacles and opportunities. Presented by Dr. Jabeen Fayyaz. Dr. Jabeen Fayyaz, in addition of doing FCPS in pediatrics, she holds Master in Health Professional Education degree. She has done a tremendous work in the simulated education in pediatrics. After completing her fellowship in emergency medicines and simulation, she is now currently enrolled as PhD candidate in MGH Harvard. Dr. Jabeen Fayyaz.
Thank you so much, Shania. Can you hear me clearly and can you see my slides?
Yes, ma'am. We can hear
Perfect.
you.
Perfect. Thank you so much. First of all, I would like to congratulate each one of you for all your hard work on putting it together, this amazing conference, despite of all the challenges that you guys are facing, and you guys are doing such an amazing job via Indus platform. I'm first of all disclosing my topic is not at all clinical. I'm just going to talk about how you can learn all these clinical work that everybody, all the talks are being here, that how can you learn all these things by utilizing a simulation-based education, by embracing the disruption, what are the opportunities and barriers. I'm going to talk about a couple of platforms, but I do not have any disclosure or any conflict of interest or financial affiliation with any of them. I would like to acknowledge the land on which SICKITs operate and where I do work. Today, I'm going to talk about a background of simulation-based education, some of my experience based on my own experience, as well as the literature search, that if you want to kickstart simulation-based learning, what is needed, and then finally the kind of my passion, which I'm very passionate about, that how to implement, or what are some of the examples of face-to-face versus virtual simulation and what you can achieve. If we look at the simulation-based education, the medical education over the decades have undergone a several paradigm shift over the time period. Specifically, there is a huge shift toward educating physicians who can effectively work together as a team and practice patient-centered care. If you look at the simulation-based learning, it integrates not only the cognitive, but also the behavioral skills and technical skills in a environment which is safe and realistic, so that the learners can practice their not only medical content learning but also technical skills. They can make mistakes and they can learn from those mistakes. It doesn't matter what kind of fidelity you will have in your places, but the realism matters most, how real the experience you can make. And then in turns you will see that you will not be able to achieve not only the medical knowledge but also the team dynamics, the communication and system improvement ultimately, which will all work toward the improving care of your patient. If you look at the history of the simulation, it mostly have been derived from the aviation industry. And you can see the most kind of, in 1910, the most primitive plane simulator that has been built of a wooden structure that continue to evolve. And in 2010, they have been to virtual reality or augmented reality. In healthcare, 1968, Dr. Michael Gordon, through American Heart Association, utilizes a simulator to teach their learner the cardiology, how to interpret or hear the cardiology, heart sounds, heart murmurs, and then the journey will continue. And now the simulation is being recognized as a disruptive technology, with many new things coming up, from virtual reality to augmented reality to high fidelity simulators. So definitely, simulation is an educational revolution which will not only allow the learners to have immersive experiential learning, but also let them reflect on their own learning. And you, as educators, you can make them learn not only knowledge, skill, and attitude, but also let them in an environment which is psychologically safe. You can provide them on-demand learning where they can do repetitive tasks. For example, if I take my example, when I did my residency, the only time when I can learn into intubate is if I get an opportunity, or God forbid, if there's a patient who is sick, or there's no way that he's going to survive, or he or she is not going to survive, then I will learn the intubation, which we all felt is not the right way. So in a simulated environment, you can let your learner teach, learn, and then provide better care to their patient in a more better way. If you look at the Kirkpatrick model of learning, you can the simulation will allow all levels of learning to your learner, and also allow all level of assessment as well. So you can utilize the simulation to learn, and then you can utilize the simulation to assess their learning as well. If we want to kickstart any simulation program anywhere, I have been to Pakistan, to Middle East, and now I'm working in Canada. At any place, whenever you are aiming to achieve something, or you want to start, the 7 steps that I have come across will help is to identify the need, that what is the need, what is your niche that you want to address. Engage all your stakeholders, team up with your like-minded people who have the shared vision. Develop some local expertise, which is always sustainable and cost effective. Always start small, but have a eye on a big picture. Continue to evaluate and improve your programs, and then definitely disseminate and share through research all what amazing work you are doing. That matters a lot. It will not only attract the collaborators, and you never know, you will find some funding, and that will be result in the sustainability of your program. Now, shifting the gear a little bit about the practical aspect of simulation. Simulation can be face-to-face, and then it can be virtual or distance simulation. Some of the examples of the face-to-face simulations are interprofessional team training in situs, which is implemented in SICKITS in 2014, and now it has been implemented in many low resource setting, and it has been shown to be an effective pedagogy for testing your environment, for letting your learners learn in the actual workplaces. And I am definitely giving example of emergency department because I work in the emergency department, but it can be it is being practiced in all the setting, in family medicine setting, in clinical setting, in the floor setting. And what actually are simulation in team training in situ? These are simulations which are physically integrated into your actual clinical environment, which will provide you a method which is more reliable, because what you practice in sim center and how do you practice might not be applicable to your clinical setting in terms of resources available, in terms of processes that you will do. So it is taking beyond the sim center and working in your actual clinical environment, and then seeing how the similar kind of knowledge that you have achieved in the sim center is actually working in your practice or not. At SICKITS, we do have 12 scenarios. We run it every week, and usually in the morning time, just because it's less busy time for us. And these are unannounced, and all the teams, interprofessional teams who are actually working in the department will will run those team training in situs. So it will develop a sense of team dynamics, and then it will allow the physicians to work closely with the nurses, with the respiratory therapists, with the clerk, and then they will be more prepared when such situation arise in their actual clinical environment. How do we choose the curriculum? It is based on the common clinical presentation, as well as our MMM reviews, as well as any safety concern that is brought up to us, or we are implementing a new order sets, new processes. We will utilize the team training in situs. I will show a video now that is a pre-COVID video, so it might show a little bit different dynamics than now. So let's watch.
Good morning at 9:43 in the morning, and you are in the emergency department. A nurse rolls in a patient for you and tells you that this is a 5-year-old boy brought in at 9:43 a.m. today and was complaining of blurred vision, vomiting, and severe abdominal pain. For any additional history, you may ask me. We do not have a parent in the room right now. here just but that's her number.
What was the age? What was it?
Sorry?
Age, what was it?
He is 5 years old, coming in with blurred vision, bumbling, and severe abdominal pain.
All right, so I'll be the TTL or the coaching leader. Can we please get monitors on the patient? We're going to do a primary assessment. Airway, we can get it assessed as well. And if we can do pupils while we're in the airway, that would be really useful.
So this is one of the example, and we do utilize checklists, which are case-specific checklists. This is no way to evaluate any person. It is just to be kept by the nurse educator and the physician educator to guide what are the steps, what are the things they need to focus, and then it can be utilized later on in the debriefing. And then the teams is being evaluated through utilizing a team score, which is a validated score. After running for so many years this team training in situs, we realized that maybe once in a few months training might not be enough. So what could be the way to move forward where, like, we as a faculty, like I got the teaching when I was in my residency program, somebody provide me feedback on my performance during my residency, but afterwards when I become a faculty, there are very, very few occasions when somebody provide feedback to me that, Jabeen, this is the best way of doing it, or this is something you can improve. So it is so important to continue having our skills maintained, because like, how can I ensure that whether it's me working or Jonathan working or Sabah working, my child when go to the hospital will get the right care, and it will be the uniform quality care that they are getting. So on the same concept, we implemented this competency-based medical education program, which is one of its novel kind in Canada for our faculty member. So the faculty are participants, the faculty are the facilitators. It's usually 4 half days in a year, and it has got a technical component and a resuscitation component. We developed a website which has the pre-reading learning material, so nothing is a surprise for anyone. They know what they are going to be taught. They have all the core guidelines, pathways, order sets, and they come in, they perform in a team, and the checklist is already there. They know the steps. It's just like to learn through working in a team, through peer, and then to get the feedback that how we all are functioning and what are the opportunities one can get better. So these are some of the examples what we are doing face-to-face simulation. Coming to the tele-distance simulation, which is in the market for almost more than a decade, but it come to limelight just after this COVID. COVID has brought this to a limelight just because the face-to-face simulations are not possible. And then people realize that how simple it is or how innovative it is to have just an internet connection. And then you can connect the trainees and facilitators all over the world, and you can ensure the similar kind of learning to your learners. So if you look into the literature, the telesimulation is always been there as an innovative tool for health professional education, because it does not only allow to eliminate the distance barrier, but it will also serve as a kind of collaboration, which can be interinstitutional, interprovincial, or maybe intercontinent. So the time barrier, the distance barrier has been broken by this telesimulation. One of the example is just the pre-simulation, pre-icon as a pre-conference workshop that we conducted for faculty development as a simulation instructor workshop with the Indus Hospital. And this is a 2-day workshop that we conducted, and it is the first of its kind where we empowered the 18 faculty members and residents from all over Pakistan to be equipped with the tools that will help them to incorporate the simulation-based learning into their curricula. And there were 24 international facilitators, local and international facilitators that participated in this workshop. And then what we got, Alhamdulillah, accreditation from the Hamad Medical Center for our workshop. The second thing which I want to share is the virtual resuscitation room that has been created with my colleagues in McMaster and University Health Network in Canada. The concept of the virtual resuscitation room is the same as we work actually in our clinical practice. A sick patient arrives, we work as a team to manage that patient, and then we debrief and learn through it. So only difference between the virtual resuscitation room and actual simulation is that usually we do that face-to-face, either in a sim center or in our clinical practice, but now the virtual resuscitation room has replaced it. And virtual resuscitation room work on a very simple pedagogy, like we are communicating audio video through this platform. You can use Zoom, you can use Microsoft Teams, and the virtual resuscitation room is built on a Google slide by utilizing the concept that people can simultaneously perform their task. So this is our virtual resus room, which is a first room where the patient, all the monitors and all the gadgets are there. This is a virtual medication tray, and this is a virtual respiration cart. This is our virtual defibrillator. The efficacy, usability, and acceptability has been recently published, and you can see the result. It has been very highly rated, and it is quite acceptable and applicable. And there are many, many universities all over the world, globe, that are utilizing it. How we adapted at SickKids, like we adopted it for our learners and faculty as well as fellows who are rotating are already based at SickKids or are rotating through the SickKids, just because the face-to-face learning was not possible. So we developed cases, we did a faculty facilitator training, and then we run those sessions. Each session there are 4 to 6 participants, 2 facilitators. We run 20-minute sim and then 25-minute debriefing. And then up till now, we have covered 20 sessions with 75 plus learners, which are from all over the programs, junior, senior, fellows, practicing physicians, and then we are able to develop 15 new cases. This is how one of the example of the virtual session, which is running. And then we got the evaluation, almost 46 in number, and it was comparably evaluated. The yellow is virtual simulation and the gray is the face-to-face simulation. And you can see the evaluation on the design as well as the facilitator evaluation, in addition to the overall satisfaction from the session, were comparable. The advantages of the VR are we are able to collaborate, we are able to interact, it is responsive, and it is very simple and low cost. I think $15 we spent on some of the functionality that we want to incorporate to buy or subscribe for that. But this collaboration does not stop there. There's a 8-week module that we run past year. It just finished in October with the collaboration of Indus Hospital, Emergency Department, SickKids, and Yale University. It's an 8-week simulation module for the EM resident, and we utilize the concepts of flipped classroom model with the pre-reading material available on Google Classroom, pre-recorded videos using Puzzle, and Q&A session with a content expert followed by virtual simulation. This is how our classroom look like. This is organized into modules with pre-reading material, resources, recorded sessions provided to the learners. And this is one of the procedural sedation session that we are doing. So what we are able to achieve, 22 EM residents at Indus Hospital got this training, where 6 PEM Yale fellows participated as a co-facilitator, and there were 30 facilitators from the Indus Hospital, from Pakistan, as well as from international fidelity of SIM experts. We got the accreditation for this module from Royal College of Physician and Surgeon of Canada. So this is one of the perfect example of turning barriers into opportunities, and there are many, many small opportunities are present, what you guys are doing in your curricula, where that can be transformed into simulation-based education. So my thoughts for later thinking is simulation is a disruptive technology that promote adult learning, and it can be utilized in each curricula in many different ways. Faculty development and research is key to promote your simulation-based learning, and distance simulation has a unique role that we can utilize by breaking this barrier of time, distance, and it is a very low-cost solution as well. So please do not limit yourself, unlock your potential. And I really love the quote which Martin Luther has said, if I cannot do great things, but I will try to do small things in a great way. This is my email address. Please feel free to communicate or contact me. I'm happy to further share of the small things which I just shared, and I'm happy to support and collaborate in any way that I could. Thank you so much. I really appreciate all of your patience listening, and I hope that is helpful for all of you.
Thank you so much, Dr. Jabeen. This is very informative session regarding importance of the simulations and its importance in a clinical practice. We would like to have you involved with the Indus faculty in the Q&A sessions. Thank you for all that. Our next topics to be discussed is newborn survival and health in Pakistan by Dr. Zulfiqar Bhutta. Dr. Zulfiqar Bhutta is an icon of the pediatrics, and I think I will not able to do justice in mentioning his achievements. However, his brief introduction is that Dr. Bhutta is founding director of the Center of Excellence in Women and Child Health in the Institute of the Global Health and Development at Aga Khan University, as well as the inaugural Robert Harding Chairs in the Global Child Health, Ibn Sina Scholar in Global Child Health, co-director of the Sick Kids Centers for the Global Child Health. Dr. Bhutta leads large research group in Toronto, Karachi, and Nairobi, focus on the scaling up evidence-based intervention in community settings. In 2020, Dr. Bhutta was awarded for the honor of the Fellow of the Royal Society. Um, Dr. Bhutta's next.
Hello, good morning, good afternoon, ladies and gentlemen. I am absolutely delighted to be with you today. I'm just trying to locate how I can upload these slides of mine, and I just wonder if somebody in the background could help me identify how one can do this. I have this thing open in my desktop. If I share, can you see my screen?
No, sir, we are not. We cannot see your screen.
This is not standard. Can you see me?
Yes, we can see you.
Is there a way of uploading, sharing the screen on this particular format? This is not standard Zoom.
Sir, double click on PowerPoint.
Which PowerPoint?
Do you have a PowerPoint presentation in front of you?
Yes, I do. I do.
Do a double click on that.
It's open. It's open. The PowerPoint presentation is open. My screen is open.
And then click on the share, which is shows the below
taskbar.
Below the taskbar, there is a option of share.
Yes.
Click here.
Yeah, but it wants it on my computer, and then says upload files. एक second, let me try and do something else. Okay, I think what it wants is these files in a very specific format. Just 1 second, please.
Okay.
Apologies. This should have been practiced because the format, I thought the format would be very simple Zoom. Okay. All right, let's see now. Says processing. Maybe it's going to take its time.
Yes.
It's very slow.
And there is there will show the share screen option.
I can't see a share screen option at all. I mean, I see, yeah, well, I mean, I see the share screen and yeah, there we are now.
Then there is, then choose your PowerPoint option was there.
Icons are so small, I can't actually see them. Okay, 1 second, let me just put it on full screen mode. All right, release maximum screen mode. Damn it. Can you see the slides for? Can you see the slides?
No, sir, still not.
Well, I've done what I could at my. It's sharing the screen.
Email the slides and you can. What is the window screen? Okay, he can email the slides and you can share while he's presenting.
डॉक्टर जबीन कह रही हैं.
Email करवा दो.
हाँ,
नवीन बात करो.
हाँ, एक लेट.
ये स्लाइड जो हैं
Now,
ये शेयर
Dr.
हो रही
Bhutta,
हैं,
because,
नजर आ रही हैं अपने उसके ऊपर.
Ji, Sam, this is Dr. Sabha. Dr. Bhutta, is there an option that you can email your slides to us and then we can play it for you?
It's a fairly large thing, but I can see the slides on my screen here, and I just wonder if you can see them as well.
No, we don't. So, do you think it's not be possible for you to email them?
Who do I email them to?
I'm giving you the email address. I'll just WhatsApp to you, okay? Just in a second. I'm WhatsApping you.
My concern is it's a pretty large. It's a 17 megabyte file.
Dr. Bhutta, please check your WhatsApp.
Yeah, I'm sending it.
Okay.
But it's a 17 megabyte file. I don't know whether it'll go through or not.
Let's see.
But the whole purpose was that there are lots of animations on those slides, and that's why I was concerned that this may not work. Dang it. I can see the slides on my screen. आपके उसको भी नजर आ रहा है मुझे. It says slide 1, neonatal mortality. I've got 3.
Okay, नजर आ रही है. Okay, हो गया.
Yeah, Dr. Bhutta, now we can see your slides.
All right. Are they on full screen? Yeah, nahin.
Yeah, they are on full screen.
Okay, excellent. Wonderful. All right. So let's, I'm sorry about this delay, and let's begin. I am thrilled and very happy that I'm able to join, although it's always a bit tricky given the time. What difference? What I thought I would do today is talk to you with this largely national audience in terms of what is the situation around newborn health and survival in Pakistan and various challenges and opportunities. And I'm very grateful that we have this chance to discuss this. Now, I want to be sure that you can actually see my slides moving. So can you see the next slide, which says Pakistan has the highest neonatal mortality globally? Can you see it change? Can you please confirm that you can see this next slide? So Pakistan is widely regarded as the country with the highest neonatal mortality rate globally, despite its relatively better resources than many other countries in low and middle income countries and GDP per capita income. And there are many aspects to this, but the stuff that I wanted you to see is not only is the rate high, on the x-axis here is the ratio of estimated to expected neonatal mortality compared to many other countries, even Afghanistan. Not only is the rate high, but the rate has not changed very much according to these global estimates. This is a UNICEF report. And one of the big questions that we had to address was, is this something that is really true, or is this just a statistical aberration? So to do this, one had to look at exactly the data sources that we have. And the most of the data sources that we have are the demographic and health surveys that have been taken sequentially since 1990. And if you look at them, Pakistan has reduced its child mortality rate reasonably. But the corresponding reduction in neonatal mortality in this red bar has been relatively slow. And if you look at the overall rates of reduction, while the child mortality reduction is around an average of 1.4% reduction per annum, the neonatal mortality reduction is less than 1%. And this is something that has been puzzling people, epidemiologists as well as public health individuals in Pakistan for a very long time. We wanted to confirm whether or not this mortality pattern that was seen in the demographic and health surveys was correct or incorrect. And as a result of that, 2 years ago, we conducted this large national mortality and cause of death analysis for newborns, children, and adolescents nationwide. And this, as you can see from the sample size, was a largely district representative survey done across the entire country using the sampling platform developed by the Bureau of Statistics. When you look at this, absolutely, we were able to confirm at that time that the DHS data from 2017-18 were indeed correct, because if you look at infant and neonatal mortality patterns, absolutely. I mean, our estimations were 39.6 and the national were 42 per 1,000 live births. So Pakistan does indeed have a major problem. But in addition to not just the rate, what we were able to generate from that survey was an assessment of what the major causes of mortality were and also their distribution patterns. So if you look at maternal deaths, the major causes of maternal mortality are the ones that you see here, and they're the fairly well known. While some of them do not have a direct bearing on the newborn, but others absolutely do. Things like pregnancy-induced hypertension, eclampsia, obstetric hemorrhage, and obstructed labor. These things account for a very significant chunk of maternal mortality in the country, and they also impact on something that we don't talk about very commonly, which is stillbirths. So if you looked at stillbirths in Pakistan, around half of all stillbirths or a little more were related to intrapartum stillbirths. They're babies who die during childbirth. So they're really an extension of birth asphyxia. And in turn, the etiology or the causes of those are these preventable disorders: pregnancy-induced hypertension, maternal infections, antepartum hemorrhage, and obstructed labor. So these four disorders are largely responsible for the huge burden of intrapartum stillbirths in the country. On under 5 deaths, the important thing to take home for this audience is around 56% of all under 5 deaths in Pakistan are related to newborn deaths. That's a large chunk of neonatal of child mortality in the country. And if you look at the etiology of these and timing, a large proportion of these deaths are early, fairly early on the day of birth or on the first day of life. And the big chunk of these are done by about 1 week of life. So by 1 week of life, the vast majority of neonatal deaths in Pakistan have taken place. And the bulk, as you can see, are on the first day or 24 hours after birth. Early neonatal deaths, if you were to reclassify them by etiology, 3 disorders are responsible for early neonatal deaths: asphyxia, prematurity. Between them, they are about 3/4 of all newborn deaths. And then there is a contribution very early from neonatal infections also. When you go to late neonatal deaths, beyond first week of life in Pakistan, the vast majority of these are related to infections. I mean, there is some residual effect of prematurity, But neonatal infections account for about 80% or thereabouts of all neonatal deaths in Pakistan. So the news in here is that most of these are preventable and they're relatively straightforward in terms of developing programs. So the big question that arises is, why are we seeing what we are seeing? So let's start by looking at the distribution of these deaths. Now, some years ago, I had published these data based on the national analysis of where deaths were taking place. And as you can see from our health system, which is fairly well distributed with these primary care centers, intermediate centers, and referral centers, when it comes to maternal and newborn care for complications, people typically vote with their feet and they try and make their way to the upper ends of the health system. And therefore, in this analysis from almost 10 years ago, we had shown that 50 to 60% of all neonatal deaths were at home in community settings. About a third occurred in the health system in facilities, and 5 to 10% died while seeking care. Now, this pattern, fortunately, in the most recent survey that I've just shared with you, the VASA survey 2018, has changed somewhat. And now what we are dealing with is around 2/3, 60% or thereabouts of all deaths taking place in facilities. And the proportion of primary care deaths has gone down. There's still about 38% of all newborn deaths at home. But we are now losing a lot more in facilities. People do make their way. And this is also consonant with the change that has taken place in country with facility-based births. So we should be able to do something about it reasonably well. But why have things not changed? And if there is change, what have been the barriers? So if you look at overall the coverage of maternal and newborn interventions, if you look at maternal care in pregnancy, antenatal care, 4 visits or more, tetanus immunization, all of those have gone up. If you look at these compared to 1990, there's a pretty significant change. We have now close to nationally around 60%, 66% facility births, and also skilled birth attendants. But some issues are really problematic. And if you look at early initiation of breastfeeding, something that I am very keen on, our overall rates are still below 30%. So there are many basic newborn interventions that are really not taking place at primary care level. Overall, it looks like if this is a composite coverage index across a range of child interventions, skilled birth attendants, facility births, immunization, overall, it looks like a number of things have gone up. Each one of these dots is a district of Pakistan. So straight away, what you can see is that there is tremendous disparity, tremendous difference between various districts in terms of coverage rates. Just take care seeking for pneumonia. Coverage rate is in some places close to around 90%, and in some districts is down to 50% to 60%. So tremendous variation, inequity. Now, this inequity that you see over here is notable for all child health interventions. So over here are the immunizations, rehydration, pneumonia. The red dots are the poorest people in any given population. So these are asset quintiles. The yellow and amber dots are the relatively rich. So you can see that the coverage rates are relatively low for the poorest, for everything that you see here. But this is greatest for maternal and newborn care. So if you look at coverage data for many interventions related to newborn outcomes, maternal care, these gaps are enormous. And they are one of the reasons why, because targeting for newborn care is so poor, that we face what we face in terms of average numbers. So to summarize why things have not changed, the diagnostic, first of all, we have to accept that in Pakistan, there's a big issue with status of women and care of women. We have very little information on some of the things that I've told you about. There are no data on early perinatal mortality. We have no low birth weight data from Pakistan based on actual measurement. Most of these are estimates. And the data that I've showed you today in terms of asphyxia, premature sepsis are the first data in almost 15 years that we've been able to generate as to what is happening to these major etiology envelopes. In terms of our interventions, a lot of the focus of the governments over the last several decades has been on the primary care program. And the Lady Health Workers program has been the backbone of what you're trying to do for maternal and newborn care. And now we see that it really cannot do anything in terms of the large number of deaths that are taking place in facilities. On facility-based care, there has been almost no information at a national level on quality and availability of newborn care in those services. And as a result, there has been no targeting for perinatal and neonatal mortality reduction. So if you don't have a program, if you don't have a national focus, how do you expect things to change? They can only change by secular trends, and that's extremely slow. So another important thing that links with it is also our population growth rates. In society, the perception that newborns are, quotes unquote, expendable. So if you lose a newborn baby, it doesn't matter. You'll get another one within 2 years. I mean, that concept is also linked to the high population growth rate. And therefore, until and unless babies start to survive and families start to recognize every baby is equally precious, particularly female babies, we are going to see this continued high burden of early infant and neonatal mortality. So what can be done? Now, theoretically, and on the basis of global evidence, a lot can be done. And people have developed, particularly for deaths that take place at this bottom, the primary care level, community-based packages, outreach services, and there are also, of course, facility-based care packages that we now need to look at very seriously. And the big question is, what will be their relative contribution to this? So there has been a lot of emphasis on primary care, as I've said. I mean, my own team has worked on Lady Health Workers program since its inception, and we've conducted some of the largest cluster randomized trials of looking at what this particular program can do, which is focused on rural care and providing access to particularly marginalized women in rural population. There are close to around 100,000 of these lady health workers still in the system. So we looked at this in HALA, and I'm going to summarize the HALA trial for all of you, which is, now a little old. It was done almost 15 years ago. And this trial was focused on whether these government health workers, in coordination with community support strategies, could reduce neonatal mortality. So it's a cluster randomized trial, almost 1,400 villages, and basically had these community support groups and community volunteers that supported the action of lady health workers. And lady health workers largely worked in community settings with women on promoting evidence-based essential newborn care and care seeking for mothers themselves. And the trial showed that it had a big impact on neonatal mortality, about 15% reduction overall. And if you took early neonatal mortality, but if you took late neonatal mortality, the impact was above 20%. But we also saw something that we never expected, which was a reduction in stillbirths, as you can see here. And one of the major reasons for stillbirths reduction was this increase in facility births that we saw in that district on the basis of promotion of care seeking and facility births. So it worked. Then the big question arose with the government is, could these lady health workers do a little more? And in Nusura Feroz, we conducted this large cluster randomized trial over 5 years, where we encouraged these lady health workers to do more in primary care setting. And in Nushero, the intervention was inclusive of recognition and domiciliary management of birth asphyxia, referrals for early neonatal sepsis, and encouraging these lady health workers to be present at the time of delivery. So we expected to see a larger impact on neonatal mortality from this intervention. And we used some of the available evidence-based modalities for care, including HPB-like interventions at that time. Now, the reality is only a small proportion of lady health workers could or did attend births. I mean, there were more in the intervention areas compared to almost none in the control, but it was very small, only about 5 to 10%. Then we saw an impact on neonatal mortality. The neonatal mortality in the intervention area was lower than the control areas, but it was to the same extent as we had seen in HALA before. It was largely related to community mobilization and only to the extent of 20%. So we did not really see a major impact on neonatal asphyxia, on primary care management of complicated problems, telling us that there was a ceiling effect that you could get from those interventions. More recently, our group has worked on a more comprehensive package of interventions to just answer the simple question. Now, if you did more, if in addition to these primary care strategies and working with the private sector, if you could also bring in some facility-based care and improvements in referral patterns, could you see change in maternal, newborn, and child mortality? This big Umeed-e-Nau project has recently analyzed some of his interim findings, and this is focused on rolling out evidence-based packages at scale using both public and private sector platforms. Our role is catalytic. This is a very large project. It was focused on the poorest districts. So the poorest districts were selected for this large quasi-experimental study based on high mortality rates. So these are not the better districts. These are the worst possible districts on district development ranking. And as you can see, these include districts in southern Punjab, Muzaffargarh, Rahim Yar Khan, in Balochistan, Jafrabad, Nazirabad, and these districts in Sindh. So these districts, altogether, 8 districts, have almost 16 million populations, one of the largest evaluations that has been done in the country. And I'm going to show you some preliminary data from this, looking at both newborn maternal focused districts and child focused districts. So the first thing is we were able to show that intervention coverage increased enormously. And remember, we are not delivering the interventions. The government is. The lady health workers and the other health workers in facilities, they are the ones who are delivering care. Our role has been largely around our previous experience of promotion and facilitation. So a number of things have increased in all of these districts over the last 3 to 4 years, ranging from early initiation of breastfeeding and ranging from postnatal care, immunizations, facility-based births. And they have been much greater in terms of impact. On the x-axis here is the change in intervention coverage between baseline and end line. And you can see it is greatest in the red dots. The red dots are the poorest quintiles. So the relative impact on the poor within these populations of these interventions has been greater. There has been a significant reduction in neonatal mortality across all districts, much greater than secular trends. So obviously this has had a huge impact, which has been highly significant. And most of that reduction in terms of percentage point reduction is around 23, 24% within a period of 2 years. But we've also seen that this reduction has varied within districts based on where people live. So even in this, so this is Nasirabad in Balochistan. And as you can see, much of the mortality reduction that has taken place here is in the relatively more urbanized part of the district where people live closer to a facility. So even within a rural population, there are these differentials. And in reaching out to remote populations, one has to do additional things in these districts to promote transportation. But the impact on neonatal mortality overall is very clear. And that impact is there very early, as you can see in this Kaplan-Meier curve. And that difference remains all the way through to the end of the neonatal period. So I have no doubt in saying that you can reduce neonatal mortality in some of the poorest districts of Pakistan, provided you deliver a more holistic package of care. So if you were able to do this, the models tell us, the LifeSafe tool model tells us that we could make a lot of difference. So the model tells us that we could reduce neonatal mortality in high burden districts significantly by the early focus on care during labor and childbirth, but also correspondingly by improving the care of the small and sick newborn. This is the package that we are now expanding in facility settings. So you have to have a combination of what you want to do at the grassroots level, at the primary care level, but also what you need to do at the secondary care level in these facilities. And the interventions that you need to do to make a difference are these basic interventions. So none of these are rocket science. Yes, you may require some neonatal intensive care, but the vast majority of things that you need to do are things that are possible in district settings. And these packages of care for reducing prematurity-related mortality or asphyxia-related mortality and aftercare infections are all possible within our system. And 2/3 of deaths in Pakistan can be prevented through this actionable package of care. And we actually modeled, I want to take you through these details as to what could happen by etiology. And in Pakistan, the models indicate that you could significantly reduce prematurity and asphyxia-related mortality using this particular approach. And we even calculated what the contribution of each intervention might be to reduction of neonatal mortality in Pakistan. So what's the way forward? So let me conclude by saying what is being planned in this country, and I will then tell you exactly how we will go about this, because this plan has been recently approved by the Prime Minister's Health Task Force. So firstly, we absolutely need to continue to strengthen the community engagement and mobilization component with a focus on preventive care. So although, yes, we have seen an impact, but it is patchy, and that needs to be strengthened. But the most important thing that we need to move on to is to strengthen the quality of care for mothers and newborns in districts and in secondary facilities and district headquarters hospitals across the country. And that will require supporting and establishing KMC units, special care units for newborn care, and importantly, appoint or train pediatricians in those districts in newborn care. So work that Indus is doing and other hospitals are doing on improving capacity. Some of the stuff that Jabeen was talking about on simulations and on improving quality of care of health staff has to be done at scale across the country, focusing on some of the very remote and rural districts. And this will also require improving our neonatal transport system currently, which only happens in big cities and is relatively patchy. And we need to monitor. So आपको जो मैं data बता रहा हूँ, the data that I've shown you is data that we have largely generated from research. It does not occur in DHIS. In our existing data systems, there is absolutely very little reporting of neonatal deaths, even maternal deaths. So until we report and until we see these at regular level, we will never know. The powers that may be will be never made aware of what is happening. So absolutely information systems have to be put in place, and they have to be linked to advocacy and accountability. So in the first phase being launched this year is a rapid assessment of perinatal and neonatal facility care capabilities. This is called the National Neonatal Survey. We are developing this right now, and the National Institutes of Health will implement it. And it will focus on infrastructure and staffing and training needs assessment in all district headquarter hospitals and the leading private sector hospitals in these districts of Pakistan. But I hope right after that will be the initiation of the planning process for development of a national perinatal strategy with the provinces. Work on this will start as soon as we have the actual granular data, and we hope to finish it by this fall, by September, with the development of the national perinatal strategy. And it will be costed and it will be supported by the insurance scheme. So fortunately, money is not an issue at the moment, because for newborn care, the health insurance scheme will cover it in both public and private sectors. So we are for the first time looking at something that we can afford. And I am particularly pleased to follow, as I said, on Jabeen's presentation on simulations and a rapid district training model, which COVID-19 has shown can be done remotely. It doesn't have to bring people in an expensive manner to big cities and displace them from their points of practice. This can be used using online web-based training systems, and it must be made mandatory for all district-based staff, particularly those with very low levels of neonatal training. And this will also generate the survey, the list of commodities and supplies that need to be assured in these district hospitals. And then the implementation phase of this large national perinatal strategy, if approved by the provincial governments, will start in October, hopefully, with the rolling out and with the end of the Sustainable Development Goals reporting period in mind. Currently, our DHIS reports less than 5% of all existing stillbirths and newborn deaths. We need to change this, and it is my task as the chair of the Board of Governors of the National Institute of Health that this will happen through the Center for Data Monitoring. And it will lead to an accountability. I think we need to make both the district health officers as well as the district political infrastructure accountable for what is happening in their districts. Now, the problem so far has been that this has been totally de-linked from the political system. And what for the first time we want to initiate is to report on maternal and newborn mortality for every MNA and MPA in their respective constituencies. So we've been able to generate what has happened in all political constituencies for variety of indicators. I'm going to show you this this indicator on skilled birth attendance for various parts of the country. So this is where this was for various constituencies in 2006. And as you can see, there has been change, but the change has not been uniform. So if we have this data, we ought to be able to tell every local politician what is happening to maternal and newborn status in their constituencies, and therefore, even beyond district administration, make the political economy of newborn health much more centerpiece than it is right now. So thank you very much for your time, and sorry about the early glitch. Our vision is to create a Pakistan where every newborn survives and every newborn deserves his or her first birthday. Thank you very much for your attention.
Thank you so much, Dr. Bhutta. This is very informative talk. I'm really grateful for all the excellent lineup of the talk by our experts. We will now move to panel discussion with our speakers online, and our panelists include Dr. Mohammad Fariduddin, the Chief of Pediatric Medicine, the Indus Hospital, Dr. Sabah Shahid, HOD of the Pediatric Department, Indus Hospital, Dr. Samina, ID Consultant, and Dr. Farhana, Pediatric Nephrologist, and Dr. Rian, Hematologist at the Indus Hospital. The floor is open for the questions now. And
ये कैसे इसको सबको ले आएंगे?
Are we all here?
करीब हो जाएंगे. ये मैं आपको दे दूं, आप क्वेश्चन ज़्यादा सही से सुन पाएंगे.
It was a pleasure to have you all. Lovely talks. We really enjoyed. And I think now the floor is open for discussion. I think all of us, Dr. Ali hasn't joined us yet. Can Dr. Ali call in, please? So I think I'll start the floor with questions. Jabeen, it was pleasure hearing you talk. You've been my student, and I'm really proud of you today. So we had, I think, I didn't see many questions in the chat box, but there were a few questions I had on my own, and probably I'll start with those. My first question is to Dr. Ali Akbar. Thank you very much, sir, for joining us and giving a lovely talk. I recall that you have been in Pakistan also taking care of cystic fibrosis patients here. So in your, I was just wondering that in your experience, what difference did you note in our children as compared to children of cystic fibrosis in the West?
I think, first of all, I would like to thank everybody, the conference organizers in this hospital and the speakers, and really enjoyed all the talks. And it's nice to hear Professor Bhutta as well, and very valid comments and suggestions. With regard to your question, the differences that I'm seeing for the CF care is that the diagnosis is being made late. There is no coordinated care. There is no particular center who specializes in the CF care. And I feel, and I'm ashamed to say that the medical profession feel somehow unwilling to ask for assistance and help and advice. And this is where the children are actually suffering. If we can coordinate the care, if we can liaise with each other, we can share the information, that would be a lot better. And I think locally, we also need to make sure that the medical profession can help together with the governmental authorities to make the availability of the medicines for these children available to them at an affordable prices, because I think that's also another big issue. So there's lots of things which I mentioned in my final slide about the CF centers, the coordination of care, the transition between sort of the different doctors, patients moving from one place to the other, and nobody really having particular clue. And they can link in with me. I have made my email, my mobile number, and our WhatsApp group available to everybody. So I'm quite happy for people to share that. And I think until we link with each other, share the information, seek the help, and seek the advice, we're not likely to improve things. So I think it's the working together, networking is most important.
Thank you very much. Does anyone else have any question? Dr. Ali, then we can probably move to the next speaker then. Oh. Farhana, we can't hear you that very well. Yeah.
Can you hear me better?
Yeah, it's better now.
Okay, so a quick question was that how do you identify, like we see a lot of post-tuberculosis bronchiectasis and changes that look quite similar to cystic fibrosis. So is there, I mean, what would be some of
We lost you again, Farhana.
I think if I may come in, the question was likely to be, if I may complete, is how do we actually recognize that the changes that we see at a later stage of possibly TB things are linked in with the cystic fibrosis or not? I think it is very important. Cystic fibrosis mainly presents, as I said, with respiratory and gastrointestinal problems, usually from early infancy and childhood, whereas the TB is likely to present later on, and there's going to be the other people who would be contributing to the morbidity and mortality of these patients by spreading the infection. So I think history taking is extremely important, to dig into the history to see when the problem started and how they started, and take it from there. TB, you will invariably have lots of problems, but by the time you actually develop the complete respiratory complications of TB, it's quite late. And CF should definitely be diagnosed and picked up much earlier than the diagnosis of TB with those complications.
Oh, that was a very comprehensive answer. Thank you, Dr. Akbar. If I may, my next question is to Jabeen. Jabeen, it's been a pleasure working with you, and we're really grateful for your constant engagement in this hospital emergency students. So I think it was, you had a pre-con workshop too, which went very successful. And I feel that's the need of the time now. COVID has taught us many things, and one of it was how to use our gadgets more wisely. So how do you see the prospect of simulation-based education in Pakistan? Because in this hospital, there are a couple of online programs we are doing, online education. So do you think it will be feasible to use simulation-based education for those online courses as well?
Thank you so much, Dr. Sabah. It's a wonderful question, and I completely agree with you that it is the need of the time. There are many, many asynchronous learning modalities which you can utilize in addition to the face-to-face simulation, and they are very, very cost-effective. As I am into this space, I started to explore a little bit more, and people think that there's a lot of money in North America. Even for our training program, we have to look for something which is cost effective and which is easily available. And the other thing for technology is, again, you can adopt it easily as well. So that is also very important thing. So it's one thing is the cost, and other thing is how will you train your facilitator to conduct, first of all, develop simulation based education on that platform, and then conduct and facilitate so that it is the technology will not become a barrier to a learning. So I would say I'm still in the process of working with the Indus team emergency department, and we are planning to utilize a platform, and I would take the name, but with the full disclosure, I don't have any financial affiliation or financial benefit. Affinity Learning is one of the platform which we are in the process of exploring, which will provide a huge opportunity for converting learning asynchronously through simulation, and then strengthening it with the face-to-face simulation. So I would say there is a huge opportunities, and there are many, many things that we can do together, and I'm looking forward to work with you all.
We're looking forward to working with you too, inshallah.
Jabeen, if you have a model that can be used in rural Pakistan for neonatal, particularly practical procedures, resuscitation and beyond, let me know, talk to me in terms of what can be done at scale. Thank
Sure,
you.
sure.
And plus also, Dr. Bhutta, I've realized this, that we have so many residents with us. I just realized that medical education needs to be strengthened in terms of malnutrition and neonatal care. And, simulation-based courses for medical students, undergrad, postgrad also, would be a great initiative to sensitize our students to the problems.
It exists. I mean, we had put it there at the time when I was the dean of faculty of pediatrics at CPSP. If you look at the residency program, it has all of that stuff. At the undergraduate level, of course, the curriculum needs to be reviewed, and Adil Heather is responsible for doing that right now for all disciplines. So I agree, absolutely. The focus has got to be, in my eyes, things like exclusive breastfeeding, early initiation of breastfeeding. These are things that ought to be bread and butter for every graduate and every trainee. But to some extent, what we need is particularly on the job education, CME, and training of people who we induct into district services. Many of our students and trainees just largely remain in urban settings, don't go to rural areas. So there is that big divide in terms of knowledge and capabilities also. But I agree with you, absolutely. A curricular reform is needed.
Any more questions? One question for Dr. Bhutta. It was a wonderful talk, and I've always been a fan of you. And we were discussing the neonatal mortality and the state we are in currently. One thing as a clinician and as a pediatrician I'm noting is postnatal care. So many preterms, they have growth faltering in the postnatal period as well. And if we look at the under 6 mortality, then it's quite high. But unfortunately, the guidelines, the management guidelines, and the statistics, the screening, they are not that robust at the moment. So WHO talks a lot about malnutrition management and screening for malnutrition from 6 months till 5 years of age. But for under 6, still, I feel there's a gray area. I would like you to talk about under 6 mortality and what can we actually do to make the system more robust and more evidence-based.
So, I mean, obviously, mortality is one piece, and that was my major focus of attention. But for child health, you need to go way beyond mortality to morbidity survivors. So, give you an example. Roughly about a quarter to a third of all births in Pakistan, particularly in rural areas, are small for gestational age. And if you throw in prematurity, a significant chunk, we estimate around 10%, are both preterm and small. So these are babies at the highest risk of dying and also the highest risk of adverse outcomes. What I did not speak about today is the burden of disability that in rural populations is associated with early neonatal problems. Shanaz Ibrahim has recently published data that he actually generated a number of years ago, looking at the prevalence of disability in rural Pakistan. And it's quite significant. I mean, if you look at our hospitals, every pediatrician would see these post-asphyxial children with disability, cerebral palsy, and residua. So, to answer your question, we need a lot more information on the distribution patterns of child health and mortality, which is representative. Surveys can give you those snapshots every 6 months. And that's one of the reasons why I'm very keen and focused, and particularly in my new role, as trying to strengthen national data systems and health systems on trying to improve our monitoring capability. Again, Pakistan has done so well in COVID comparatively, compared to other countries. One of the major reasons why we did so well in COVID was because we had the information. We could check, we could tell where patterns were, where the disease clusters were. Even today, we know what the positivity rate in various cities is. How do we do that? Because we set up an information surveillance system. Now we have a system like that also developed in districts for maternal child health. The problem is we don't use it. And as I just said, less than 5% of the mortality is actually reported. So we need to improve all of this. And what will happen then is when you do, is policymakers and managers will begin to realize what a major burden exists early in life in the first 6 months. So it's all doable, but as so many things in life, innamal a'malu binniyat, niyat. So if our objective is to improve things, and our niyat is saf, which means that our mission is unadulterated by other considerations, things will happen. And that is something that we all need to do as a fraternity of pediatricians together.
And I think I would like to use this forum that there seems to be a disconnect between the major hospitals when it comes to management of children, regarding mortality, neonatal mortality, or under six mortality, or under six management of kids. So I think policy makers need to have a consensus together to see how we can work together. If we can overcome that, probably we'll share the data more and we'll work together more effectively as a team also.
True.
So I would ask any of the speakers if they have any comments or questions, then they may do so, or any panelist.
Well, thank you and I hope
Can I please ask, can I please add something?
Ji, go ahead.
Sure. Ji, Dr. Faid, you're on.
Fareed, go ahead.
Yeah,
I think
please.
yeah.
So first of all, I would like to thank you all. That was a wonderful. I would say the presentations were really wonderful, and it was really something that we were looking for a very long time. And yes, physically we are not there, but yes, we are connected through like heart to heart. And this is something like this is a very different learning curve for us too, like in this COVID era, how to communicate with others and how to be united. So like this is all that I wanted to say. Yes, please.
Thank you all. It was great session. I thank all the presenters, especially Jabeen and Dr. Bhutta. Despite of the time constraint, they made an effort to share their thoughts with us. And Dr. Ali Akbar also, because he's in UK. So I would like to call and end to the session now. It was great having you all. Assalamu alaikum.
Thank you very much indeed. Assalamu alaikum wa rahmatullahi wa barakatuh.